Welcome to the video training series. This is the presentation for lung anatomy and solid tumor rules for version 1.7. These rules cover diagnosis 2018 to 2020. I'm Lori Summers. I'm the trainer at the Iowa Cancer Registry. And so let's get started. The anatomy of the lung and the structures are important in order to understand the staging and surgery. When I get hung up when I'm doing lung cases, I always go back to the anatomy. Here are the primary site codes and structures in the lung. Laterality must be coded for a lung primary. The mediastinum is a space that contains structures in between the lungs, including things like the heart, thymus, the great vessels, lymph nodes, and esophagus. So you can also see in the left lung, the cardiac notch. Let me point that out right here. So this is where the heart lies. And then I want to point out the fissures that divide the lobes. So the left lobe has the left lung has two lobes, one fissure. The right lung has two fissures. This oblique one is lower, and then the horizontal fissure divides the right lung. So you can see that the right lung has three lobes and the left lung has two lobes. This is table 1 in the solid tumor manual. Table 1 contains terminology used in the physician documents. You'll see these terms in scans and reports to determine the location of tumor masses. And so think that you're looking for the location of the tumor, not lymph nodes. Use this resource first to determine your correct site code. This table has terms and anatomical descriptions that are not in the purple ICD-0. Column 2 indicates whether the term is used only for the right or the left, or if it's used for both. So this is not a laterality field. This is just helping you decide if this primary site could be left or right, or is it only right, like the right middle lobe. You can see there's no middle lobe for the left. If you're coding, if you have main stem bronchus, you can code that to C340 when it is specifically stated in the op report and or documented by a physician. Main stem bronchus is the first one listed on our table. If it says hilar mass, you can also code it to C340. So hilar, hilus, hilum, if that's where the mass is, you can code that as your primary site. There is a terminology for C34.9. Notice bronchogenic is in the list. So this is really a location. It is not a histology. Think of bronchogenic carcinoma as a location, kind of a generic location, and why you would code it to C34.9. If you have something described as infrahilar tumor or mass, then you would code that to the C34.9. Okay, so the definition of the hilum. The hilum or the hilus of the lung is found on the medial aspect of each lung, and it is the only site of entrance or exit of structures associated with the lungs. Remember, hilar is similar to the hilar area of the kidney. It is the exact same purpose here in the lung. It's where Those great vessels go in and out of the organ. So hilum and hilus are the same thing. So here's a couple questions from Ask a SEER registrar. What guidelines for coding primary site do we have when the tumor is described as a hilar mass? And so on the table, on the last slide, we know we can code that to C340 when the lung tumor is described as a hilar mass. So then the next question, what primary site code do we use for infrahilar tumor? And the answer would be a C34.9. If it refers to infrahilar area of the lung and you don't have any other information. So infra would be below, suprahilar would be above, but they're talking about this area of the lung. The lungs are separated by the mediastinum. This area or space shown here in green is where, again, the heart and trachea, esophagus, many lymph nodes live. There's no lung tissue in the mediastinum, but there are lymph nodes. So just another picture of the mediastinum, terms you might see in imaging, like superior mediastinum up in this area, posterior mediastinum, anterior, and middle mediastinum. So think of this as a space. It's not an organ, but it does contain blood vessels, ducts, nerves, the heart. Okay, the carina is another important term in lung anatomy. The ridge at the base of the trachea, the windpipe, that separates the openings of the right and left bronchi. So this could also be called the tracheal carina. If you see widening or distortion of the carina, typically this means there are subcarinal lymph nodes that are involved. So text that information, but it usually means there's lymphadenopathy around the bifurcation of the trachea. The main stem bronchus, the C34.0, you can see here by these arrows. This is the main stem bronchus. Once it starts going down and narrowing, then it's the bronchus. And these bronchus or bronchi are in each of the lobes, the farther down you get away from the main stem bronchus. I like this visual because it shows the actual lung tissue surrounding the bronchi. You can see in this visual, the main stem bronchus is not as long as what it was in the other picture anatomically, but it still has a main stem bronchus here. And I do like to think of the lung windpipe and all of the bronchioles, if you think of it as an upside down tree. So the trachea would be like the trunk, the bronchus would be like the branches, and then the bronchi, as they continue to divide and subdivide into smaller branches, you get to the bronchioles, and then you get to the alveoli. So where the gas exchange takes place would be similar to the leaf on a tree, which does kind of the same thing for the tree. And just another picture. All of these are just anatomical reminders of places in the anatomy for a lung. Just use them as references as you're learning some of these terms. The alveolus, or the cup-shaped outpouch, removes dust particles and debris from entering the lungs. And this is, again, where the gas exchange takes place. So you start up here in the trachea, and you get all the way down here into the alveolar sacs. And just one more picture, the entire lung has alveoli all throughout. So obviously think gas-air exchange all the way throughout the lung tissue. Again, you can see the main stem bronchus, you can see the trachea, and then as you get into different lobes, you will have different bronchi. Bronchogenic carcinoma, again, is not a histology. It's more of a general lung cancer term. So you would code that to C34.9. If you had a contiguous tumor, a single tumor that involves or invades or bridges other lung tissue or subsites, you would code it as C34.8. If you have a central tumor, it is most likely going to be squamous cell carcinoma. Those arise in the hilum and the bronchus, whereas peripheral tumors, those farther out away from the main stem bronchus, are going to be adenocarcinoma or large cell tumors. These are often farther out in the lung tissue as opposed to being in the bronchus. This is a radiographic diagram of areas of the lung. These terms are used in imaging. The apex, here is the central area of the lung versus the peripheral area, and the base. And so 25% of lung cancers are in the apex, maybe 25 in the base. The rest are going to be peripheral or central. Pancoast tumor is an anatomic designation of a tumor. It's not specifically a histology. There's no morphology code for a Pancoast tumor. But this lung cancer starts in the upper lobe of the lung and extends outward, and it can destroy the ribs, the clavicle, the vertebrae. It might invade the brachial plexus of the neck, and it can cause neck pain. These also could be called superior sulcus tumors. If the clavicle was on this picture, you would see that the apex of the lung lies above the clavicle about 1.5 to 2 centimeters. Okay, that's it on anatomy. We'll go ahead and move into the solid tumor rules. They were updated in December of 2020. Again, these are for diagnosis 2018 to 2020. And these changes are in accordance with the current WHO and CAP guidelines. So they are assuring us that any of the new histology codes, as WHO and the CAP summary, continue to update things. The Lung WHO books were updated, and so now they've moved all of those histologies into the solid tumor rules. You should be able to find the majority of your histology codes here in the solid tumor rules. Just a reminder about the in general instruction section of the solid tumor rules. This is the basic details for all sites. Every manual, you will hear me talk about general instructions. So I go here when I want to look at the ambiguous terms that can be used for histology, or if I can use them. I go here to remind myself about navigating the solid tumor rules, the timing rules. Multiple primary rules do not apply to METs. So if you've got a MET to the lung from another organ, these rules will not apply for lung. Also, the general instructions give me priority order for using documents for histology and definitions. So once you get into the lung solid tumor rule, There are site-specific rules pertaining only to lung cancer. So many other primary sites metastasize to the lung. It is important to rule out mets from another organ or site before abstracting lung primary. If you have lung mets, those could also be from the lung primary cancer that you are abstracting. So there is a difference between a new lung primary that is diagnosed with mets at diagnosis versus, is this a different primary and I've got mets to the lung from that other primary. In the introduction, it also talks about the discrete foci or multifocal tumors. They are referred to as lipidic adenocarcinoma. You also will see the name ground glass features. And then do not code multiple primaries based on biomarkers. Those are used most frequently to target treatment. Here are some important changes from the old MPH manual. Changes are implemented slowly over time. So it's not unusual for a path report to use an obsolete term. Obsolete terms and codes can be used when they are only when they're the only information that you have. So if you look up a term and it says it's obsolete, you don't have anything else in your record, you have to use that obsolete term. The WHO 4th edition, which was updated in 2015, has a new classification for adenocarcinoma, the bronchoalveolar carcinoma. They are discontinuing the usage of that BAC starting with 2018 and forward, and the preferred term now is mucinous adenocarcinoma, so the 8253. Coding histology used to be from the most representative specimen pre-2018. Now we are to code the most specific histology from the biopsy or the resection. This applies to all primary sites except breast and CNS. The rules include, if you have a discrepancy, to then go to the most representative specimen, which would be the greatest amount of tumor. The new and the changed ICDO histology codes have been updated, and they are added to Table 3. So starting around page 167 in the manual, these are the new terms and codes for lung cancer. If they have a /2 behavior, that means it can only be used with this histology. If it has a /3 behavior, that means it can only be used with this histology. They are not interchangeable anymore. If you look down here, you can see the behavior is not listed on these histologies. That means it could be either a 2 or a 3. So this brings up the section back in the general guidelines. It tells you to use the priority order for that precedes the histology rule for each site. The priority order differs by site. Tissue path always takes precedence. But there is a discrepancy rule of what to do when your final and your synoptic oftentimes are different, so they don't match up. It's the same report. It's not two different reports. It's the same report, but they're not matching up. You are looking for the most specific histology if these two reports differ on the same tissue, procedure, and path report. This section is specific to lung cancer, starting on page 197. So we want to code prior to neoadjuvant treatment. There is an exception now in the manual. If your initial diagnosis came from an FNA cytology smears and it was from a regional or metastatic site, then the patient has neoadjuvant treatment and primary site resection. If you have histology from that primary site, they are letting you use that now after neoadjuvant. That is the exception. Code the histology using the priority list and histology rules, and do not change the histology in order to make the case applicable for staging. So continuing with item 2, code the most specific histology from either the biopsy or the resection. The most specific usually refers to a subtype or a variant. And the histology rules instruct you to code invasive when you have both invasive and in situ. And note 3, if you have a discrepancy between the biopsy and the resection, you have different histologies, different rows, code the histology from the most representative specimen, so the greater amount of tumor. Here are the documents in priority order to code histology from. If you have tissue from a path report, stop and take it from there. You wouldn't keep going down the list if you have a path report. Only go to 5. Look, if the physician has stated what it is, only use 5 if you don't have 1 through 4. So a lot of discrepancy can surface between a path report that might say something, and then you have tumor board or a med-onc doctor saying something. But if you have a path and that is your number 1 priority for that primary site, stop there and take that, and don't use the physician's statement of what that is. So for use in the lung section, these terms help clarify the rules. I do want to point out non-small cell lung cancer, 8046. This is the broad category that includes everything but small cell carcinoma, which would be the 8041. So this is a huge broad category of everything else that is not small cell carcinoma. And then if you're using the terms tumor mass or tumor mass, lesion, or neoplasm, you are going to disregard those terms if they are not stated as malignant or cancer. These terms are not equivalent. They do bring up mucinous and colloid, and they talk about mucin producing or mucin secreting carcinoma. This is not equivalent to mucinous carcinoma. Okay, so we've already looked at table 1. So looking at table 2, this shows the combination or the mixed histology codes, but only come here when instructed by the histology rules. By the time you get to this table, you have already been through the multiple primary rules. You know you have a single tumor, and so you will come here and you have a mixed histology. You're going to compare the terms in column 1. You're going to find your combination code in column 2. There is a last resort code, 8255 is the last row. If you get there, try to go back through your histologies and make sure you didn't miss something. You can use this code. It is not preferred. Okay, also with table 2, do not use table 2 if you have invasive in situ, because the coding rules tell you code the invasive. Do not use table 2 when you have one histology that's described as differentiation or features. And don't use table 2 if your terms are NOS and a subtype variant of that NOS. So those rules will not send you to table 2. So here's one page of table 2. Compare your terms in this first column, and it will give you the combination code in column 2. So we don't use this table if we have in situ and invasive. We don't use this when we have differentiation or features of. So if we had adeno with features of squamous, that's not how table 2 is used. Or if we have an NOS and a subtype variant of that NOS. These are not subtype variants of each other. Okay, so table 3. We are told in the NACER webinars, go to table 3, get your working histology first before you go through the rules. It really does help to know, do I have an NOS? Do I have a subtype variant? Am I on different rows? Get your bearings with what you have and then go to the rules. The rules will send you back to table 3 if you get to that point, and then you can decide what you have for histology. So to use table 3 as directed by the histology rules. Rare histologies may not be on the table. They are updating these as they can, but there are still some rare histologies that don't have codes yet. Send in a Ask a SEER registrar question if you're not finding your histology and it is a rare one. Remember those behavior codes. Some histologies can only be one of those behaviors, and the table will give you that behavior if that's the only one it can be. Make sure you're matching exact terms. And then think about if you have a sarcomatoid carcinoma, most frequently these are in the mediastinum. And so they are not listed in this table for the lung primary site. You would have to go to a different schema to look up that histology. The non-small cell lung cancers are that broad group of cancers. They are included in table 3. They are the adeno-CA, squamous, large cell carcinomas. So all of those are in table 3, and they do not include small cell or sarcoma. So here's table 3. Remember, the first column is the NOS. The second column is the same or a synonym. It's got the same code. And then anything in column 3 is different. So these are all subtype variants of this NOS. But if you have 2 or more of these are all different primaries. And so the rules will tell you you have multiple primaries. Okay, so after table 3 and the diagrams, we get to the M rules. Always start in the multiple primary rules. Figure out how many tumors or abstracts you have first. Then go to the histology rules to figure out your histology of the tumor you have. So in the multiple primary rules, the headers are important. You go to the correct heading. Once you're in that section, you follow that those rules in order. Stop when it applies to your case. So here are the headers for unknown if single or multiple. And obviously, if you don't know, then it only fill out one abstract. If you have a single tumor, it's always a single primary. So if you don't have complex cases, you only have one tumor, you know it's always going to be a single abstract. Okay, so now we're in the multiple tumor header and the multiple tumor rules. So you can skip to the other two headers if you know you have multiple tumors, and these rules then will help you to tell you if you have multiple or a single primary. These multiple primary rules work whether you are comparing a tumor in your database to a new tumor, or if you have new tumors happening at the same time. So M3, if this applies, you say yes and you stop. If it doesn't, you say no and you keep going. So if you have multiple primaries when there are separate non-contiguous tumors with primary sites that differ in the second or the third character. So that would mean if you had a lung and a colon, it's differing at the second and the third character, you would say yes and you would stop. You know you have multiple primaries. So if you have a lung, let's say you have a C34.1 and now you have a C34.9, it does not differ at the second or third character. So you say no and you keep going. M4 is when is our timing rule. If they were disease-free for greater than 3 years after the original diagnosis or last recurrence. So that's the timing rule. And then M5 is when you have a small cell carcinoma or any subtype variant. And then another tumor that is non-small cell and or a non-small cell subtype variant. These are multiple primaries. It doesn't matter if they are in the same lung or in both lungs. M6 is a rule that's going to tell you to go to table 3. You will abstract multiple primaries when you have separate non-contiguous tumors that are 2 or more different subtype variants in column 3 of table 3. The timing is irrelevant. They're basically telling you if you have specific subtype variant histologies, those are multiple primaries. Remember, we're in the multiple tumor section, so this means you've got more than one tumor and more than one different histology. So these could be subtype variants of the same or different NOS histology. And so we'll take a look at how that works on the rows. But here is the example that they've given us. The example of these subtype variants are different histologies of the same NOS, where these two are 2 different NOS histologies. So here's table 3. And I just clipped out the adenocarcinoma NOS section. So colloid is 8480, lipidic is 8250. The M6 rule is telling us these tumors are subtype variants of the same NOS, but they are distinctly different. So you have multiple primaries. You will fill out 2 abstracts for this case. So remember, we got here because we have more than one tumor. Okay, so let's look at the other example for different NOS histologies. So again, lipidic, the 8250, and then we have keratinizing squamous cell carcinoma, the 8071. And the table shows that these are subtype variants, each of a different NOS histology, and they are on different rows. So this is my page break of where this other row started. So this would be a multiple primary based on M6. There's no timing stated, just that they have their own specific histology. And M7, this has to be the same lung. The reason this is not before M6 is because they want to be sure we don't have distinct and separate histologies. So we are in the multiple tumor section. It's telling us to abstract a single primary when those tumors are in the same lung and they are on the same row in table 3. So we just looked at table 3. They could be one in column 1 and one in column 3, or you could have something from the preferred term in column 1 and the synonym in column 2. So one of these is an NOS, and they're telling you that this is all the same primary. You have one tumor. So multiple tumors abstracted as a single primary. Okay, so M8, these are different rows in table 3, or you could have a combination code from table 2 and a code from table 3. So these are distinctly different histologies. Again, timing is irrelevant. All right, so those are all of the meat of the rules for having to know the histologies of your tumors. By the time you get here, a lot of the cases have already fallen out of the previous rules. If you don't know the histologies, you've said no to everything else, then you're going to land here. And you have multiple tumors, you're going to abstract a single primary. When you have simultaneous, at the same time, multiple tumors in both lungs, in the same lung, or a single tumor in one, multiple tumors in the other. Now, if you knew what the histologies were of those, you would have already answered yes to previous rules. So there are 4 notes that go along with this rule. And basically, jump clear down here to note 4. If you have multiple tumors in one or both lungs, the physician usually biopsies only one tumor or mass. They treat the patient based on that single biopsy, assuming that all the masses and tumors are the same histology. So these are all going to be a single primary. We've already looked at we know that in situ and invasive is already a single primary, and you code the invasive. We've already looked at the NOS and the subtype variant in table 3. We know that's one single primary. If you have cancer or a carcinoma NOS and another histology, you're coding them more specific. We already know that's one single primary. So we've already kind of been through all of these other rules. And we know that here's some examples of NOS and subtype variants. We know those are single primaries based on the rules that we've already been through. And then here are the multiple tumors, the rest of these M10 through M14. I did not put the notes in for this section. Pretty much by the time you get here, we've already talked about these, but you know, it's a single tumor if you have in situ after an invasive. Once you have In invasive incidents, you're not going to put on an in situ if it's in the same lung. It's multiple if you have a single tumor in each lung, except when you have proof of METs. Here's the timing rule for if you have an invasive less than or equal to 60 days after in situ. It's a single primary. It's all part of the same thing. If you have invasive after 60 days after the in situ, it's a new primary. You don't want to lose the incidence of the invasive happening after an in situ. And then if you get to M14, no other rules apply, and it's a single primary, it's a good idea to go back through the rules and just make sure that you didn't miss something. So those are the multiple primary rules. Now that we've determined how many primaries or how many abstracts we have, now move on to the histology rules to see how to correctly code the histology either in a mixed tumor or multiple tumors abstracted as one. So we did talk about the priority order for documents to identify histology, and we did talk about the hierarchical list of sources. So I'm not going to go over those again. Let's move right into the histology rules. And all of the single tumor rules, if you paired them up with the multiple tumor rules for histology, they pretty much match up except for one or two. So we'll go through these for the single tumor rules, and then you'll see that in the multiple header, these are almost identical. So H1 covers mucinous. Remember the specific codes for mucinous, and those are for lung only. And then H2 is the section for non-mucinous adenocarcinoma, and then they give you the codes for non-mucinous specific codes just for lung. H3 talks about the non-small cell lung carcinoma. And then if you have a more specific like adenocarcinoma, squamous, you can code them more specific. There are two conditions that need to be met. And then you can code that more specific. Otherwise, you're going to have to code the non-small cell carcinoma. H4, code the histology when you only have one histology present. Again, this is when you don't have a complex case, you've got one histology. Note 1 in H4 says go to table 3, get your histology and code it. Rule H5 is the invasive, code invasive when you have in situ and invasive present. So once you have invasive, you can pretty much ignore the in situ. Code the in H6, code the subtype variant when you have an NOS and a single subtype. So this is in keeping with coding the more specific histology. And then rule H7, and we're still in the single tumor section. This wording has been changed in December 2020 update. So I know in the lung webinar that NACER put out, her H7 rule looks different. This is the current updated H7 rule to code the histology that comprises the greatest percent when two or more histologies are present. There is a long list under this rule giving you examples of these histologies. And If you have predominant or the percentage listed in the path report, make sure that you're coding that histology with the greatest percentage. Rule H8 is a combination code. When you have multiple histologies, and this is the first rule that tells you to go to table 2, but only go there when the rules tell you, which I think this is the first rule that it's allowing you to go to table 2. And then H9 is the last resort histology for a lung, and it's the 8255 for mixed subtypes. 8255 does not apply to squamous cell carcinoma. But if you have adenocarcinoma with mixed subtypes, they are allowing you to use 8255. So in the early use of the solid tumor rules for lung, we found that many of the mixed types of adenocarcinoma were getting coded to 8255 because that's the rules that we had at that time. The new H rule was added now to tell us to code the histology that comprises the greatest percentage of tumor when 2 or more histologies are present. So if you have a case without percentage, you cannot use that rule, and table 2 has instructions for coding cases that you do not have the percentage of each subtype. So I say this because if you would go back and look at your lung cases coded to 8255, some of them might be coded differently than what you would code now. So this histology would be coded to 8551, which is what the current instructions tell us. This was changed actually a year ago. And so the old solid tumor rules instructed you to code this to 8255. But now we know take the highest percentage. So these will look familiar. They're basically the same as the single rules for the corresponding single or multiple tumors. So this header now is multiple tumors abstracted as a single primary. So as you came from your MP, your multiple primary rules, it told you you have multiple tumors, you're coding those to a single primary. This is where you would land in your histology rules to decide how to code your histology of those multiple tumors. The last rule is, again, the last resort. Code the combination code when all tumors have multiple histologies, and the combination code is listed in table 2. Only use this rule when nothing else applies. So if you get to H16, go back through the rules, see if you can find a better histology than the combination on table 2. Okay, so take out the solid tumor rule exercises. There are 10 cases to code the primary site and the histology. I will give you, typically it takes about a half an hour. If you're watching the recording, just click pause. And as soon as you're ready to start back up, go ahead and resume the recording. Okay, we'll go through each of these 10 cases, and I'll kind of walk through my navigation, my thought process through these. These are pretty basic cases to practice navigating the rules. I typically go to grab my primary sites, and I grab histology code if I need to. before I even get started, just so I have something to work with. And you can see that we have an old tumor already in our database, probably. They had a lobectomy of the right upper lobe. Now in 2020, they come back with a right lung mass. I don't see any other masses on a CAT scan. They did do a biopsy. They're calling it recurrent squamous cell carcinoma. However, we cannot use that terminology to decide. We need to run this through our rules to see if we have a new primary or not. Because they've taken out the right upper lobe where the tumor was, we know it's not in the right upper lobe, but it could be in the middle or the lower lobe. So I've just penciled in the C34.9. And so we first need to go to the multiple primary rules. M3 asks about this primary site. So we want to compare the primary site codes at the second and the third character. And we say no to this, so we keep going. The C is the first character. So the second and the third character are the same. They do not differ. And we say no and we keep going. M4 applies to this case. This case had a clinically disease-free period of 6 years. And M4 says it needs to be 3 years. Also, if you don't know or it's not documented whether the patient had a recurrence in between this time, you go back to the date of diagnosis to compute the time interval. Even though the doctor says this is a recurrence, note 4 in Rule M4 says the physician may state this is a recurrence, meaning the patient had a previous lung tumor and now has another lung site, but follow the rules and do not attempt to interpret the physician's statement. So this case will be a new primary. The primary site code is C34.9. The histology would simply be coded 8070/3 for squamous cell carcinoma. And you can get that off of table 3. Okay, so this case has a 5-centimeter mass in the right upper lobe. We also have more masses in the right lower lobe, and we have lesions in the left upper lobe. So we have multiple tumors. The rules are going to help us decide how many abstracts to complete. So in the multiple tumor header, M3 does not apply. And we only have, we have no pathology on this report. We only have a physician finding. So he's probably referring to the CAT scan, but they have not biopsied any of these. So M3 does not apply. And actually going down through the rules, none of these apply until you get to M9 because we don't have any histology to know if one is an NOS and one is a subtype variant. So we get to rule M9 where we have simultaneous multiple tumors in both lungs. So we stop at M9 and it tells us this is a single primary. So we know we're going to do one abstract. Our primary site would be C34.9. We don't know where this tumor started. Most likely it could have started in the right upper lobe, but we don't know based on the CAT scan where this would have started. Bronchogenic is not a histology. We know that is a location. And then since we don't have path, we know by our order of where we can take our histology from, we can take it from the CAT scan. And so all we know is carcinoma. And so that would be an NOS code, the 8010/3. So this case, we have a biopsy of a single mass in the left lower lobe. It does have two different kinds of histology in one tumor. So we can go to table 3 and get a working histology. We need to know if spindle cell is a subtype of an NOS, or what table 3 tells us. The histology rules tell us to code the most specific if it's described as a subtype variant or a type. So we can tell from table 3 that squamous cell is the NOS. Spindle cell is not a subtype of squamous in column 3. So the preliminary codes here, squamous is the 8070, spindle cell is the 8032. And we need to go back. We know we have a single tumor, so we know that's a single primary. We need to go back to the H rules to single tumor header. And that starts at H1. We actually I got to H6, code the subtype variant when there is an NOS or a single subtype variant of that NOS. According to table 3, squamous and spindle cell are on different rows, not a subtype variant of one or the other. So really, I kind of stopped here. I wanted to make sure this is not what I have based on what table 3 told me. H6 does not apply because we have two distinctly different histologies in a single mass on separate rows in table 3. So we need to keep going. And rule H7, we need percents. We don't have that. Rule H8 applies. We have multiple histologies in a single tumor. And we need to go to table 2, looking for squamous cell and spindle cell. And table 2 does show that there's a combination code for these two histologies. Squamous and spindle cell, and the combo code is 8074. So don't get confused. Remember, you've got a single tumor. You've got multiple histologies. So these aren't always multiple primaries because both histologies are in a single tumor. You're just trying to figure out how to code the histology. Okay, so again, we have a single tumor, but we have complex histology. If you went to the MP rules, multiple primary rules, it will tell you a single tumor is always a single primary. Now we need to figure out what our histology is. And this section of the manual has changed. This is the original case. And so we have a single tumor. We want to go to the H rules. This description of a neuroendocrine tumor, the large cell neuroendocrine or the combined large neuroendocrine carcinoma. In table 3, this is one histology, 8013. And really, H4 would be the rule because you have one histology present. You wouldn't really know that unless you went to table 3 initially and got a working histology code, and you would see that it is now listed under large cell neuroendocrine carcinomas. And the note per the WHO is that both large cell neuroendocrine, NOS, and combined large cell neuroendocrine are both coded 8013. So we don't have a combination of this code and another code. Both of these are coded to 8013. There is no subtype variant of this. This is an NOS code. There are synonyms, the combined large cell neuroendocrine carcinoma. That's what we have in the right middle lobe. And so this is an 8013. Okay, this was a left upper lobe lobectomy. We have a diagnosis of invasive adenocarcinoma NOS. We also have a subtype of mucinous in the lung. And so going to, we have one mass or one tumor, so we know we have a single primary. Going to the single tumor histology rules, working through what we have, adeno, NOS, and a mucinous subtype. So that, remember, H1 and H2 do cover mucinous, but we don't have a pure mucinous tumor. We have an adeno with mucinous. So we basically get to H6. We have an NOS and a single subtype variant, and they are asking us to code the mucinous subtype. So that is the 8253. And remember, for lung, those mucinous are specific codes. So H6 fits this case. Okay, so for this one, the patient has 2 lung tumors. The first one is in the right upper lobe and it's papillary adeno. The second one is in the right lower lobe and it's invasive mucinous. So I went to table 3, I got my working histologies, just so that I know what I'm working with when I get through the rules. Both of these are distinct subtype variants of adenocarcinoma. So let's go through the rules, starting at, we have multiple tumors. So we need to go through the M rules first. And M6 fits this case, which says abstract multiple primaries when separate non-contiguous tumors are 2 or more different subtype variants in column 3, table 3. So we know that's what we have. And so it's telling us we need 2 abstracts here. So it doesn't matter, you can make one of them tumor 1, the other one tumor 2, and then we need to go through the histology rules to see how to code each primary tumor histology. So now basically you divide these up and they're each their own single primary. So start in the single tumor section. H4 is that simple code the histology when one histology is present. Table 3 confirms the histology for papillary as the 8260/3. Same thing with tumor O2, except our rule is coming from H1 because that's our mucinous pure mucinous carcinoma 8253/3. Okay, so this one has several tumors in the right lung and the left lung, but they only biopsied this right upper lobe tumor. They all range around 2 centimeters in size. This one shows small cell carcinoma. We don't know what any of these are. So starting with the lung multiple primary section under the multiple tumor heading in Rule M3, move through the rules. We cannot stop at M6 because we don't have the histology on all of the tumors. Stop at M9, simultaneous multiple tumors in both lungs, fits this case. And then remember note 4, I put there at the bottom. So this is a primary site C34.9. There's one primary per Rule M9. And the histology, you have one histology, so Rule H4 tells us that this is 8041/3. You code the small cell carcinoma. Okay, we're almost to the end of these. Case 8, again, we have one larger 5-centimeter tumor that they biopsied in the right upper lobe. We have other nodules in the right lung, but they only biopsied one. It's squamous cell carcinoma. So hopefully you're starting to understand now, going to the multiple tumor header again. Go through the rules, stop when you can say yes. We cannot stop at M7 because we don't know the histology of all the primaries. Tumors have to be the same histology in Rule M7. Keep going to M9. Abstract a single primary when there are simultaneous multiple tumors in the same lung. Again, note 4 applies for this case. The histology, you only have one. Rule H4 says code the histology when one histology is present, and that's the squamous cell 8070/3. Okay, case 9. This patient has a 2-centimeter tumor in the left lower lobe. The tumor mass shows non-small cell lung cancer consistent with squamous cell carcinoma. Remember, when we have a single tumor, it's always a single primary, but we do need the H rules to help us figure out this histology. So go to the H rules, the single tumor, and there is a specific rule when you have non-small cell lung cancer. So stop at H3. The rule states the case must meet the criteria in the first 2 bullets, which I've added here at the bottom of the slide. If not, code 8046. So I don't feel like the text in this case is good enough to use either of these bullets. I don't know if this is clinically confirmed by a physician. There's no identifier where this is coming from. I don't know if the patient is being treated for this histology, the squamous cell carcinoma. And so for this case, 8046 is probably the best histology that you can come up with, because these 2 bullets have to be confirmed. If the case does not meet the criteria in the first 2 bullets, code the non-small cell lung cancer 8046. Okay, this case has one tumor. So we know it's one primary. We'll start in the histology rules. we have adenocarcinoma with areas of squamous differentiation. Looking back at those rules right before the H rules start, remember we have some terminology rules, and this one here at the bottom says code the histology described as differentiation or features only if there's a specific ICD-10 code for the NOS with NOS differentiation or features. Do not code differentiation or features when there's a specific ICD-10 code, when there is no specific ICD-10 code. So going to table 3, I wanted to see if there was a specific code listed for this histology. And I grabbed the adeno-CA. I did not see anything that was a specific histology code where it said areas of squamous differentiation. So you cannot code that, and you have to end up coding the 8140/3. For more practice, the solid tumor rules on SEER Educate have 5 cases for this time frame of diagnosis. So work through those if you want some more practice. Here is an odd named malignancy, and the answer that I found on Ask a SEER Registrar. This is the type of histology questions that SEER is searching for, so they can address these odd histologies. So is there a better code for the SMARCA4 deficient malignant neoplasms other than just the generic neoplasm code, the 8000/3? This is not included in the solid tumor rules. It's not in 3.1 or 3.2. And the answer is code this to 8020/3 for now. WHO has not proposed an ICD-10 code as of yet, but they did ask the pathology experts coding, and they suggested coding this to undifferentiated carcinoma until they are better classified. All right, thanks for listening. Please email me if you have any questions or if some of the rules are not seeming clear to you.